know if Anton or Dr. DeJoya have a different.
It's working for me.
Okay.
Yeah. Well, I think it just keep my joint warm, and when you start playing, start moving, it's sort of like you stretched already. It prepares it a little bit better, but again, it's a personal. There is no much research behind it. Do you use this?
Right, and if you look at the football, remember, Tony, when they started the football players who wearing knee braces, and it's a dilemma about what. First of all, the knee is a very complex, and it's just not a hinge. That's number one. There's rotatory motion that goes on in there, and so, putting a brace on it which inhibits the motion is a little bit of a problem. It goes back to this message to take home. You have to ask, what's the mechanism and what works. I must say I haven't found with osteoarthritis, for example, of the knee, that braces are terribly helpful unless there's instability. If you have instability within your knee, that would be another kind of a problem. But they just what does work is what we like is insoles of cushions for your shoes. I'm telling you, that does work. There's some studies actually that show that, and in terms of a little bit of bracing, I'm just looking at Dr. Scholl. Dr. Scholl, he was both a orthopedist and a podiatrist.
I know that.
I found a little book, that Dr. Scholl wrote in one of the, in the used bookstore there back in the turn of the century. But foot pads and within the shoes, and physical therapists are actually good at that. Looking at kind of what you should do, and because what happens to your foot, the kind of looking at the mechanical stresses that are present there, you can really dissipate some of the stresses and decrease some of the strain on your knee, especially on the inner compartment. So actually, there have been some. There have really been some rheumatologic studies that
Terry
show.
brings up the point too. Remember how we were talking about high impact activities?
Right.
One of the things that Dr. Scholl's do is it provides a cushion to minimize the impact even of walking. And that brings up a point too. When you go into an exercise program, you should absolutely make sure you're in a good set of exercise, cross-training, running type shoes, because remember, all those were created to absorb impact. And that's,
they are.
They work. So, whenever just think again, the basic concept is impact is a killer. So you're doing all the stuff necessary to reduce impact, and putting those inserts in, getting good shoes, modifying the activities you do is also part of that process.
One facet, and maybe Megan can give us her perspective, though. I like analogies, and this analogy, perhaps you've heard the bathtub analogy. And the bathtub analogy, how much water do you put in the bathtub? Well, you put enough in to cover you up, but not to go over the side. And it's the same type of thing. I tell patients about that in terms of exercise. They need to know the threshold. You don't want to exceed that threshold, and you want to pace yourself. You want to have your, in terms of your level, to kind of be in the bath and it's comfortable and all the rest. Because once it goes over the side, and that's what happens. See, our brain is set up. We're learning a huge amount about pain processing. And Tony said is correct. We process pain a little bit differently, each of us. And think of the athlete that breaks their ankle. I think of Ben in the football game. Some gargantuan person throws you to the ground, you land on your shoulder, and you still are able to play football. I'm not sure how he did that, actually. Because I'm sure he certainly bruised something in there, and you impinge right on your rotator cuff, and so, but you're able to suppress this, and so that's one we have to think about, especially with arthritis. It's not no pain, no gain. You don't want to overlay use pain as a guide. I tell patients try to get kind of right before that point. Don't overdo it, because once that happens, then the water's out of the bathtub, and then it is a problem. And then actually you tend to stop exercising. That's what. So what do you tell people? How do you tell them how to pace themselves and the threshold? And
start off small is really my recommendation, and everyone has to be looked at on an individual basis. But just starting with minimal. If you're doing a strengthening exercise and you just want to try doing 2 or 3 reps and then just building up from there. And it's really very individualized, and that's why the education part is so important, and working with someone that can help you to kind of see where your goals are and where you need to limit yourself.
And just one last word on braces. I think all of us would, as was mentioned, some of the sleeve type braces that hold the heat in, they do seem to help patients, but most of us don't believe in the big bulky braces that for a couple of reasons. Number one, they don't really work, but number two, as typical U.S. citizens, you think that you're going to buy something that's going to fix the problem, and all of a sudden you say, oh, my brace is going to fix this. I don't have to exercise. I don't have to lose weight. I don't have to move it. And it's all false. So it's better to think about, getting a sleeve and exercising and losing weight and doing the things, be more active, and don't expect any brace to fix those things for you, particularly arthritis. And this is for, go ahead, Luna.
I'd like to add something to Megan's start small. I was doing some work in Los Angeles for several weeks, and I came home. The combination of a long flight, over-exercising while I was there because I was walking a lot, and this was in the early stages of my knee problem. I didn't even know then that I was going to be having knee replacement. I came home, I could barely walk at all. And so I decided, well, I can't just stay in bed. So I started walking in my bedroom for 1 minute just to get a little bit of exercise in my brain as well as in my legs. And then after a few days, I started adding 2 minutes and 3 minutes and up to 5 minutes. And then I thought, well, if I can walk around for 5 minutes, I can go outside and walk in my driveway for 5 minutes. And gradually, I built back up to being able to walk for a half an hour at a time. So nothing is too insignificant an amount of time to get you started.
Another follow-up question, and we talked a bit about this, but the question, it's a quote, pain is the deciding factor. So everyone's heard that today. If arthritis already being in your knee implies it will eventually get worse, but I may not be having as much pain, doesn't it make sense to hasten the surgery while you're still younger and healthier than to postpone it until pain controls the timing of surgery? LaDonna?
I would have no basis for which no professional basis on which to answer that question. I would just say that it's a drastic measure, and I can't imagine that a patient would be in a position to decide that they might need preemptive surgery. I mean, that's really what you're talking about, isn't it? Mm-hmm. You answer that, or someone else answer that.
Well, I can. First of all, again, it gets back to the basics that pain is the driving factor. Because if even people that have bone-on-bone on arthritis and they're not having a lot of pain and they're doing what they want to do, we don't offer surgery to them. The issue of age and whether it's going to get worse are non-issues anymore. Yes, arthritis always gets worse. We expect it. Most arthritis we heard is wear and tear. So it will get worse, and maybe you should get x-rays every 1 or 2 years, but I still tell patients that pain's the driving factor, and your body will know, will let you know when it's time to have any intervention, whether it be injections, medicines, or surgery itself. And the too old or too young, I think, as you've heard, a lot of things have changed in 5-10 years, and there isn't anyone too old or too young. And you're not going to, things aren't going to change so dramatically that you have to worry about another problem intervening, like a heart problem or a lung problem, those kind of things. And I think I've done surgery on patients. My personal oldest patient was 94 years old. Did knee replacements, and he did in some ways better than some of our 60-year-old patients. So yes, and that whole preoperative thing we were talking about. There's tests to do, and yes, it's elective, and yes, we want to make sure everything's safe and all. But I don't think you need to think about some of those things as much as keep it simple. And pain is going to be the driving factor in the treatment plans for that. Question for Anton. I have end-stage knee arthritis in both knees, and both hurt. Is it better to get both done at the same time, or to have one done and then come back and do the other one?
I mean, it's really it's a difficult question to answer, but it would be probably a surgeon preference. If you go to different doctors, some of them will do both knees at the same time. Some of them will do one knee